You as well. All right. Um, Again, it's an honor to be back with the SNaHP group, and I want to thank Vivek and the club leadership for having me back this year. This is always a highlight of the academic year, and I really enjoy this talk, not only because it allows me to treat some issues that are really a passion of mine, but I find that I get some of the best questions and interactions from this group compared to any other group. And I'm including a lot of my classes in that. So maybe that's down to me. I'm not sure. Anyway, so a bit of a caveat at the top here. As I explain, how we're going to move forward, I envision that, I'll talk, probably more or less uninterrupted, although I'm always happy to take, questions that appear in the chat along the way as I see them for about 25 minutes or so. And then there might be a slight break, a minute break. And the reason I say that is my son gets home from school at 3:31 and I have to see him off the bus. So I might have to take a minute there to get him in the house, possibly in front of the TV, we'll see. And then I'll be back. And that will give you hopefully an opportunity to think about some questions you may have. So I encourage you, not only during the course of, my speechifying, if you will, but during that break as well to develop any questions you might want to ask. And then once I return from that brief break, I'll be happy to take any and all questions that you may have about single payer, universal coverage, etc. So I just wanted to issue that caveat at the top there. All right. So I like to start these presentations by dealing with some basic definitions, perhaps in the process clearing away some misconceptions, that easily develop. I think that in terms of these key concepts, it's important to be fairly precise when it comes to exactly what we're talking about. So I like to break out the related terms of universal coverage and single payer. Okay, the two, unfortunately, in my mind, are often used interchangeably, but they are in fact different. And I want to develop a bit why that's the case. So I'll talk about that, some basic definitions. I'll talk about where we are politically as a nation and in some of the states when it comes to the drive to move us closer to universal coverage, possibly through single payer. A bit about what the prospects look like as we move forward in time out, 2022 and beyond. So that's kind of the structure of the talk today. So to start out, first off, definitions. So universal coverage. Universal coverage is a state of affairs or a state of being in which everyone or nearly everyone within a country or society has access to some form of health coverage. Now, when I say coverage, that could take the form of private insurance coverage. It could take the form of a government-funded program that in turn finances care for individuals and families. All right. So when we talk about countries that have achieved universal coverage, we are talking about nations in which 97, 98, perhaps 99% of the country is covered, quote unquote. Now, please note that universal coverage does not in and of itself guarantee universal access to healthcare. And that gap between offering coverage to individuals and actually making sure they can use the coverage to access healthcare, high quality healthcare services is, I think, one of the great struggles, not only the contemporary period, but the future as well. So our job is not done when we achieve universal coverage or get close to it, I would argue. We still have a ways to go, even in that situation, in assuring universal access. So universal coverage, again, several countries have achieved universal coverage. And in fact, you could almost make the statement, it's a bit of a stretch perhaps, but you could almost make the argument that many of the industrialized nations, major industrialized nations around the world have achieved universal or near universal coverage. So when we talk about countries like Germany, certainly the United Kingdom, Japan, Switzerland, many of the continental European countries as well, those countries have more or less achieved universal coverage or something close to it. Now, what I'd like to make a major distinction, is when it comes to universal coverage versus single payer, because many of these countries have actually achieved something close to universal coverage through routes other than single payer. So let's move on now to single payer. What are we talking about when we say single payer? The single payer in this case, in putting the single payer in single payer, if you will, is who is paying for healthcare in a given nation. Who is the chief payer of healthcare. And when we say single payer, for the most part, we are referring to a system in which government or a quasi-governmental body is the chief funder of healthcare in a nation. So that is largely what we're talking about when we say single payer. Now, is it theoretically possible to construct a system in which there could be a purely private single payer? Perhaps. Cases like that are few and far between. Certainly our, American, I hesitate to say healthcare system, because my chief argument is that what we have is not a system, but a collection of more or less random arrangements. But what we have in the United States is certainly not a single private payer. We, of course, have numerous private payers as well as public payers as well. So we have a range of payers. In fact, one of the chief problems we face is that whereas in a typical free market scenario, the more competitors you have in a given market, so to speak, the more payers you have, the more the price goes down. In healthcare, the reverse tends to be the case. So the more payers you have, the more healthcare prices and costs tend to rise. And the reason is a lot of the information about prices, because there are so many payers, is proprietary. It's not shared between payers. And so you're just continuing this battle to continue to bid prices up and up and up. And there will always be another payer that's willing to pay that higher amount. So that's a bit of the problem that we face here. So theoretically possible to have a single private payer, but generally when we talk about single payer, we're talking about a single public payer. All right. Now, what is the difference between single payer and socialized medicine? I'm glad you probably were thinking that. You didn't ask it, but I'm glad you were thinking it. So I'll approach that problem while we're dealing with definitions right now. Socialized medicine, strictly speaking, beyond the sort of scaremongering sense in which it's often used, strictly speaking, refers to a situation in which not only do public entities pay for healthcare, they fund it, but they also provide it directly. All right. So true socialized medicine is a state of affairs in which if you are a physician or a medical professional, you are more or less a salaried employee of government. And, there may be a few exceptions around the edges. There may be private work here and there. But for the most part, that is the structure of the system. Okay, that's socialized medicine. And what's fascinating is even though that's a term that gets thrown around all the time, how many times have you heard the Affordable Care Act referred to as socialized medicine after all? It gets thrown around all the time. If you look around the world, it's actually very hard to find true examples of socialized medicine. It's more of a mythical beast than anything else. There are a few. So one that I could mention is the National Health Service in England, Scotland, and Wales. Certainly, particularly in England, the NHS in its pure form is a system of socialized medicine. It is a single payer system. It's also a system of socialized medicine. You could also make an argument that the Cuban system, for instance, is a system of socialized medicine, though that is more because it is a system that is embedded within a communist structure. It is by its very nature socialized medicine, in effect. But outside of Cuba and the NHS in the UK, there are relatively few others. Italy has some qualities. It's similar to the NHS in some ways since its reform of its programs in 1978. But again, aside from that, relatively few cases and far between. So socialized medicine is fairly rare. However, single payer is relatively common. Many systems around the world have some form or other of single payer. Many of the continental European systems do as well. And there, government or some representative of government or a quasi-governmental organization is the chief payer for healthcare in those countries. Okay, the specific form it takes can vary a bit. But that is the definition, at least as far as I'm concerned. Now, depending on who you speak to, you get slightly different variants. But that's my definition, certainly, of single payer. So single payer is not synonymous with socialized medicine. It is entirely possible to have a system in which government finances most healthcare, and yet the practice of medicine mostly resides in the private sector. In fact, most countries, again, sort of follow that general model. The United States is an outlier. So it's not synonymous with socialized medicine, and it is not the same thing as universal coverage, although it does tend to be the case that those countries that offer single payer are also those countries that have achieved universal coverage or something close to it. Again, there are other ways to get there. Single payer is one popular way to do it. I would say it's probably the most popular way to get toward that goal, if you will. All right. So those are the definitional distinctions that I like to develop, sort of right off the bat. And hopefully that clears up a few misconceptions that maybe some of you had. For some of you, this might have been a review. But for others, again, you hear these terms bandied about a lot. They are used with imprecision by politicians who in some cases don't know better, in some cases know better, but are simply being cynical. So I like to clear that up right off the bat. Now, where are we in terms of our own struggles to make our healthcare, quote unquote, system, always like to use bunny ears if I can help it, our system more equitable? And does the Affordable Care Act, for instance, how does that fit in with the goal of those who champion single payer? So that's the theme that I want to develop briefly before I look to the future, perhaps, and where we might be headed, if you will. As many of you know, since 2010, our healthcare system, our collection of arrangements, if you will, has been functioning under the framework developed by the Obama administration under the Patient Protection and Affordable Care Act, or PPACA, or ACA, or Obamacare. Call it what you will. Those are all the same thing. So that's not a case where I have to make distinctions. All the same thing. All right. So what's fascinating about the Affordable Care Act is that I would argue that on balance, it has moved our system toward a state of being more equitable. But has it moved us closer to something approaching single payer? Not exactly. And the reason I say that is the ACA is best understood as a large mold. If you build sand castles or whatever, you use those molds, right? Put them on top of the sand, take them off. The ACA is in many ways a large mold placed atop our existing system. If it is extraordinarily complicated, and it is because our quote unquote system is extraordinarily complicated. It attempts to build on top of the existing system, develop the chief concepts embedded within it to move us toward a more equitable state of affairs and move us ever closer toward universal coverage. So the way it does so are through several means, most of which you will be familiar with. I always like to list at the top the Medicaid expansion. So the idea of making Medicaid available to everyone or almost everyone within about 138% of the federal poverty line. The federal poverty line for an individual is around $10,000. Initially, all states were required to expand their Medicaid programs. The Supreme Court said, nay, that is coercive. So as a result, we are in a situation now where 37 states have expanded their Medicaid programs and the rest have not. Nonetheless, it is thought that the majority of those that gained health coverage for the first time under the Affordable Care Act did so as a result of the Medicaid expansion. So even though most people think ACA, they probably think marketplaces, right? You think I'm in a New York State of Health or whatever your Rhode Island marketplace is. I'm sorry, I don't know the name. Ocean State Health. We'll call it that. It's probably not. Anyway, so the marketplaces are what's in the public imagination, when it comes to the ACA, but it's the Medicaid expansion that perhaps has been most consequential. under the larger rubric of the ACA. So the marketplaces are designed to be a place online where people can go to find individual coverage, health insurance coverage, private coverage that is affordable and that fits their needs. It has met with mixed success. Now, relatively few Americans actually use the marketplaces because even to this day, most Americans get their private health insurance through their employer, sometimes through their school, through organizations with which they are affiliated, shall we say. All right. Now, that number has been going down steadily over the last several decades, but it remains the case that employer-based health insurance coverage is the chief mechanism through which Americans continue to receive health coverage to this day. So the marketplaces are designed to cover those that don't receive coverage, don't have the option of receiving coverage in many cases through their employer or are unemployed, or for various reasons don't have employer-based care. So those are the marketplaces. That was another mechanism that was designed to increase coverage. Now you'll notice a lot of the aspects of the ACA, again, they simply build on existing elements of our healthcare system. So yes, they expand Medicaid. So they do expand part of our, one of our government programs that could potentially move us toward single payer. However, what's fascinating is that when we talk about single payer, most people, including, and I'm including here people like Bernie Sanders, Representative Jayapal, et cetera, many of those who work on single payer almost full time, if you will, politically, tend to view Medicare as the more promising program to expand in order to get to universal coverage. And as a result, Bernie Sanders and others, of course, have put forward proposals that they call Medicare for All, which I think is smart marketing. And I say that because Medicare is a hugely popular program. So if you can hitch your wagon to Medicare and say, well, what we're talking about is more Medicare for more people, that is probably the best way to sell it to a skeptical public. And so I think Medicare for All is a great way to go. However, it's important to note that what they are envisioning is not really simply expanding Medicare, because Medicare as it exists has huge gaps. It does not, at the present time, this may change, but at the present time, it does not, for instance, cover any dental or medical or dental or vision benefits. It also does not, and this surprises some people, it does not cover long-term nursing care. So a program that is designed primarily today to offer care for our seniors does not cover long-term nursing care. Instead, many of those individuals must fall back onto Medicaid. And so Medicare contains huge gaps. So you can imagine that if we were to just snap our fingers and say, tomorrow Medicare is available to everyone and employer-based coverage is gone. Well, what do you think the response might be? People would not only be skeptical, they might be angry as a result, because they would like to see, obviously, a program that's more comprehensive in terms of its coverage. So really, there are two steps here that we're looking at. And Sanders and others really, have adopted this position whereby they're saying, yes, we're going to call it Medicare for All, but what we actually envision is expanding Medicare, first of all, to cover much more in the terms of the basics of what people need in terms of healthcare, and then to extend it to a broader proportion of the populace. So you can do this several ways. You can, through some of these plans, say within 6 years, Medicare or the public program, right, will simply spread to encompass everyone. You could also, over time, lower the age of eligibility. Sort of phase in Medicare. Let's say 5 years from now, we're going to lower it to 55, then we'll lower it to 40, and down the line. That's another way to do it. And there are many different plans that fit sort of somewhere in the middle. There are also, by the way, plans that look toward moving us closer to single payer by offering what is known as a public option. Some of you may be familiar with that terminology. That's the idea that you allow employer-based and private coverage generally to continue to exist, but for anyone who wishes to do so, they may join a public program that may be not unlike Medicare, right? A public insurance program. And that program might be available, say, on the marketplaces. So it might just be an option alongside the private options that are now available, right? So that's a public option. That's actually the plan that in the past was most closely associated with President Biden. Now, It's not exactly clear, this current day, how dedicated, the Biden administration is to, making that a reality. But certainly in past campaigns, that's something that he has voiced support for. And I should add, by the way, that the early versions of the Affordable Care Act, particularly those coming out of the House of Representatives, contained a public option. So, we were very close to getting a public option actually the last time around. Now, there's been some criticism of the idea of a public option because some claim that, well, you'll have a situation in which private insurers get to keep the healthiest patients, right? And therefore they could bring down their premiums as a result because they have a healthier risk pool coming in and not having to pay as much out. So they could afford to lower their premiums. And then the public program would largely be catering to those who are sicker, perhaps those who are older, relatively speaking. And as a result would have to potentially charge higher premiums. That could create a kind of a two-tiered system. So there are real concerns about that. So in terms of the single payer plans that are out there right now, many of those who fight for single payer would like to see something akin to, the Sanders plan, the Jayapal plan, those that work toward expanding an expanded version of Medicare to the wider populace, and likely in the process over time phase out private insurance coverage, including employer-based coverage. Now, what we tend to see when it comes to support for these plans is that if you ask people, would you like to see single payer healthcare? They say, yes, sign me up. This is fantastic. And then if you follow up with the question, that might mean that you would no longer have the option of having your current employer-based coverage. Support in polling, at least, tends to go down. That's why very often it's something that is discussed, conceptually. We've now had several hearings, at the national level in Congress. But right now, as it stands today, and I hate to dash cold water, on anyone, but right now, as I look at the political landscape right now, I would say that, the passage of a single payer plan is not imminent. Now, that does not mean that 5-10 years down the road, the situation may not change. I think, my own belief is that our current state of arrangements is likely unsustainable over the long term. So I strongly believe that at a certain point, we will be faced with a choice, and many more people may become quite a bit more supportive of something akin to single payer, especially as healthcare costs continue to rise, premiums continue to rise. I think that over the long term, that is unsustainable. So I think we will reach a point where it becomes much more likely at the national level that we could see progress toward a single payer plan. So I just don't see it happening next year or two, especially given that there is a chance that Republicans could take over one or both houses of Congress starting in 2022, then it becomes highly unlikely indeed. Even if Democrats hold a narrow majority, it becomes difficult to see, how that might come about. So, I would say that over the medium to long term, it's more likely, less so over the next few years, certainly. So it may be a waiting game. Now, I should say too that there have been efforts to develop single payer plans at the state level, including in states like New York. So we have a New York Health Act that has been considered now, deliberated several sessions in a row of the legislature, and has come close to passage, actually. Now that plan would require waivers from the federal government. So that would be reliant on effectively a Democratic administration being in place, right? Let's get down to brass tacks there. It would also need the governor's signature. And we knew that Governor Cuomo was not a champion of the New York Health Act. We're not sure where Governor Hochul stands. And at this point, I'm going to have to take my little break. I will be right back. Just a moment.
If anyone has any questions in the meantime, feel free to throw them into the chat, and then we can sort of pick up from there, and then Dr. Ehlke can keep it going.
Any comments so far?
Thank you. Appreciate it.
Oh, that's not gonna...
soon. All right, I will be back in a moment, just setting up his television program. So. All right, I'm back. Thank you. Sorry about that that break. So yeah, the New York Health Act, is one that has come closer to passage the last few terms. And so at the state level, there is that effort in New York. Several other states as well have been looking toward developing their own single payer plan. So, at the present time, I think it almost more likely that we may see, one or two states move toward a single payer plan, perhaps before we see similar progress at the federal level. And so, if you're interested in single payer healthcare, I would encourage you to not only pay attention to what's happening in Washington, but what's happening in your own state capital, what's happening in Albany, what's happening in Providence, what's happening at the state level. So much of healthcare in the United States, now I come out of public health, so it's especially the case in public health, but so much in healthcare in the United States is left to the states. So if you want to know what's happening in health policy at any given time, you have to look to the states as well as to Washington. So that certainly holds true when it comes to single payer. So just because the federal route right now is blocked up doesn't mean that, we may not see some progress when it comes to state level developments. So I did want to highlight that as well, lest people feel discouraged at all. I think there are several areas, promising areas to watch, certainly over the next several years. So with that, I will stop talking again, and I'd be happy to take any questions that you may have. I'll check the chat as well. And yes, I second that, Vivek. That's a great vinyl collection in the background. Absolutely terrific.
Thank you. So I can get us started with respect to questions. So the last point you made was that, take a look at your local government, your local state government, and see what strides they've made for single payer. Are there any states besides New York that have good momentum, and if you could even call what New York has good momentum behind a single payer?
Yeah, so there are some states. Washington State, I would cite, is one state where they've actually developed a public option, at least a state public insurance program. So that is not, classic pure single payer, if you will, but it's moving in that direction. So that's something that they are just putting into, they're implementing it right now. So, I'd say that's a very promising development. Other states in the recent past have gone down that road, including Vermont as well. Colorado, there have also been some steps in that direction. So, certainly there are several states. California, every now and then you hear the possibility, certainly, that they could move in that direction. Governor Newsom has the new mandate, of course, after the recall in California. So it'll be very interesting to watch to see whether he follows up on that advantage and, gets bold in health policy. It's certainly possible. And they have a very progressive legislature there. So that's a possibility as well. A lot of momentum out west, I would say, interesting enough. Again, Colorado, California, Washington, are three states where you've seen some progress in that direction. Less so in the East, interestingly enough. Again, Vermont tried, a few years ago. It was an abortive plan at the end of the day. New York, again, there have been some steps, some tentative steps in that direction. But obviously, we've got a ways to go. Other questions?
On that note,
Yep.
didn't Massachusetts have like a preliminary form of the ACA before that was working well for them? Oh, Doctor, you're muted again. Sorry.
Sorry about that. Yeah, you'd think after 2 years of using Zoom, I'd be used to that. Anyway, so my apologies. Massachusetts actually offered the prototype of the ACA effectively, in many ways, in terms of developing an exchange, a state marketplace for health insurance. And those who developed the ACA looked to Massachusetts as their model. Effectively. And so, it wasn't just a case where it influenced the ACA. In effect, it was the direct inspiration for the ACA. It's arguably that without the Massachusetts example, there would not be an ACA. And that points to another reason why it's so vitally important to see what is going on at the state level, because not only can you see developments at the state level before, you see action at the federal level, but it can inspire future federal reforms. So if, for instance, there's a state that has a successful move towards single payer, then it's not an exaggeration to think that, well, there might be more officials at the federal level who then think this might be something that we try to scale up. So if you can build a successful model at the state level, it can be transferred, it can be scaled up to the federal level. And that's another reason why I say, watch carefully what's happening at the state level.
So I apologize if this is a poorly formulated question. I'm not quite sure how to distill it, but my understanding of healthcare financing from kind of the hospital and the provider end of things was always that public options, Medicaid patients were guaranteed losses, that the reimbursement was less than the cost of the care, and that the way to make up for that was an increased admixture of private insurance patients who would reimburse at greater than the cost of care. So you balance those two out and hopefully come out with a profit because you're a hospital. Yeah. And I was in an argument the other day, a discussion the other day with someone who pointed out that in a shift to a public single payer, if all reimbursement were to drop to the Medicaid rate, that possibility would go away. So I was just wondering if what the acknowledgement of that was in plans for a public option or a single payer system, if it was just like, we're going to increase reimbursement rates, or if it was more complex than that.
Yeah, well, that's an excellent question. So, one of the things that, we're always sort of faced with when it comes to talking about the advantages of single payer care, I tend to focus on, the arguments in favor of it that involve increasing, equity in our healthcare system. But the fact is that one of the arguments that is often raised is that it makes financial sense too, right? That we could actually bring down, our healthcare spending. We spend double what most comparable nations spend on healthcare. So the argument goes that if you build in administrative efficiency, right, and let's face it, if you bring down reimbursement of medical professionals, then of course you're going to spend less on healthcare. So I tend to de-emphasize those arguments because it all depends on what reimbursement looks like under the plan. And under single payer, there are multiple ways to envision that. So, kind of the default among critics is to say that, well, it's going to be a race to the bottom, that they're going to set reimbursement at Medicaid rates, leave it at that. And we know that Medicaid reimburses very poorly. It's one of the chief problems with Medicaid. I mean, Medicaid is otherwise an outstanding program, but it pays very poorly. And so if you were to tie all reimbursement of medical professionals to the Medicaid plan, then that would be a way to ensure that buy-in would be much reduced, potentially. And of course, there'd be a lot of opposition from physicians and other medical professionals. But there are many other ways to do it. You could say instead, well, actually, we're going to index it to Medicare reimbursement, or we're going to place it somewhere in between, what these government programs are reimbursing and what providers can expect from private insurers. So, low reimbursement, while, yes, on average, many countries that have single payer do pay physicians less on average, it's often not dramatically less. And there's no reason why it has to be dramatically less. And so it really, just goes into the nitty-gritty details of how reimbursement is structured. So getting that right, I think, is vitally important when it comes to any single payer plan. This isn't something simply of theoretical importance. This is something that it's very important to be quite clear about up front, I think, because it remains one of the chief sources of criticism, that, you get extremely low reimbursement. And related to that, you often hear the attacks about rationing. Of course, that's one of the other popular criticisms that's partly tied to reimbursement itself. And it's partly tied to a misunderstanding of rationing, because anyone who studies the American system can tell you quite directly that we have rationing. It's de facto rationing by ability to pay. And the difference is that, any rationing decisions that would have to be made might be more upfront and might be more explicable under a single payer system. But would there be rationing of care involved? Absolutely. But there's rationing of care involved anywhere healthcare is offered. That's simply, the reality. It's unfortunate that in our debate, rationing has become a bad word because it exists everywhere at all times. It's not simply something that you face in a pandemic environment. It's not something you simply face under single payer. It's something that you face everywhere, because it is well known that the demand for healthcare will nearly always rise to meet the finite supply of healthcare. And it's one of the reasons why healthcare is not a free market situation. And so as a result, scarcity means that there's going to be rationing. The question is how that rationing occurs. Is it relatively fairly, where people up front say, this is who's going to get care first and this is why? Or is it simply because, oh, you can't pay, no care, or substandard care for you? And that's what we have currently. So it's really a matter of making rationing more fair. I would like to see a world in which rationing was no longer a bad word. It's not going to happen, unfortunately. We're stuck with it, but we really have to be better, I think, at explaining that, because those are very serious arguments, that are brought out, in opposition to single payer.
Thank you very much.
Thank you. Any other questions or comments?
I don't know if this is too broad of a question, but sort of aside from reimbursement, are there any practical ways in which instating a single payer system would change the way that physicians practice medicine?
That's an excellent question. I think it would represent a significant change to the way physicians and all, many other medical professionals practice medicine. And I think it would be a change for the positive in the main. I think that, yes, for some specialties particularly, it might mean, a drop in reimbursement. So that's not a positive change, right? And that's why, I've always felt that we have to talk about single payer and the perhaps inevitable, again, it's not inevitable, right? But perhaps inevitable questions about reimbursement with a discussion about the cost of medical school. And about whether there's an argument for making sure that, perhaps as a country generally, we shoulder more of that burden, all of us shoulder more of that burden, and that medical school debt becomes much less part of the equation. So, the bad and the ugly side of this is that, yes, in some specialties, there may be a drop in reimbursement. So payment may be lower. I think where the positive changes come in is that no longer would physicians effectively have to be small business people. Most people, the vast majority, don't go into medicine because they want to attend to accounting sheets. They want to run an elaborate business. Some do, right? Some like that adventure, but many others are in it because they wish to heal people. And I strongly believe that a single payer system has the potential, certainly, to allow physicians to be the healers they were meant to be, rather than have to attend to all manner of concerns relating to reimbursement by individual insurers, office staff, etc. It could lead to a simplification and a move toward really the medical fundamentals, the reasons why many of you have decided to go into medicine itself. And so I think that's, potentially very, very positive when it comes to changing the way that physicians practice. It also, could mean that there would be less of an incentive, even a subconscious incentive, right, to practice, to order extra diagnostics, to really do the works, because, when you're paid for doing more, even subconsciously, sometimes it's all too easy to do more. Now, I realize I'm on shaky territory there, because part of that is related to the practice, of course, of defensive medicine. And part of that gets into the idea of malpractice reform, which is a whole other area, something else that we should probably discuss and debate, obviously. But, again, those are just a few ways, I think, that the practice of medicine could change. And I think it would be potentially a more positive experience for those of you just going into medicine. Other questions? Yeah, I see a question here in the chat. Oriana, it is great to see you. Oriana is in my class downstate. Great. In terms of New York, at least, do you recall what the vision was for funding? Would there be an inclusion of undocumented immigrants? I may be remembering wrong, but I believe that that group is included. Yeah, in Medi-Cal, they are. And I believe that's a relatively new development. In terms of funding, we are talking in New York about a system that would largely be funded through general revenue, through taxation, effectively. So there would be an increase in taxes associated with it. Largely an increase that would fall on wealthier New Yorkers, and that's where some of the opposition comes in. So it would require, at least in its present form, would require an increase in taxes. It would also rely on certain federal funds. So federal funding that currently goes toward Medicaid would be redirected into the new system under the New York Health Act. That's why they need to have federal waivers in order to use that money in different ways. So some of the money would come from the federal government as well. In terms of inclusion of undocumented immigrants, I'm ashamed to say I am not certain on that point, and whether they legally could, or whether that's been considered. Certainly there would be problems at the federal level. They might be able to do it at the state level, but I'd have to look at the latest version to see whether it included undocumented immigrants. My guess, and this is only a guess, so don't quote me on this, but my guess is that they would be. But I would have to look at the latest version. Again, it's changed from session to session. That's a great question.
This is just something that, came to mind when you were discussing reimbursements for physicians. Could you predict what kind of an effect a single payer system would have, at least let's say it's just a New York one, on medical school costs and student debt? Yeah, I just want to hear your thoughts on that.
Yeah. So, it doesn't include, much in the way of guidance when it comes to, medical school tuition. These are decisions that, are, made by private entities, somewhat the state, obviously when it comes to SUNY. But that's a separate discussion. And I haven't heard it connected actually to the New York Health Act, at least not yet. It's possible that if we got closer to passage, that there may be a discussion about making some changes to public school tuition. And that's something that the state could do directly, right? When it came to private institutions, again, that would be up to the private institutions themselves. Now, would there be pressure, I think, on institutions to lower tuition potentially if reimbursement, was lower? I think there would be. I think there'd be political pressure really on medical schools over the longer term, certainly, to bring down tuition costs. Otherwise debt, potentially would just be unmanageable. It's already bad, right? But it would be even more unmanageable. So, I think under those circumstances, it could force a discussion and force a debate on the topic. And that might be one of the positives, again, that kind of goes along with it. I think, again, these need to, ideally, this needs to happen simultaneously. This is not something that we should wait to talk about. But, unfortunately, it's not immediately connected to it. And so, there's nothing I think attached to the bill itself, but I think it would force, discussion, and it would probably force some downward pressure on institutions to begin to think about lowering tuition. Because again, one of the reasons why medical schools can afford to keep tuitions high is because certainly, particularly in some specialties, reimbursement is such that, the debt is for many is just barely manageable. But that delicate balance, would no longer be in effect if generous reimbursements could no longer be guaranteed. And so, yeah, I think it would force a broader discussion. I think it would place downward pressure on institutions to reconsider their tuition levels. Absolutely. How long that would take to take effect, though, that's where you run into some trouble. I'd worry about what would happen in the interim there. It could be very difficult. It reminds me of a debate that we sometimes have. There are, I said that most Americans still get their coverage through their employers. Every now and again, there are those who say, rather than having insurance coverage, at all these middle people populating the scene, we should have more care simply financed out of pocket. And that may sound terribly cruel at the outset, right? But the idea behind it is that if people were forced to pay out of pocket, then prices would necessarily have to come down. Now, in theory, is that the case? Well, in theory, yeah, maybe give it a few decades, but what happens in the interim? That's why I'd like to know, how much pain would people face in the interim where prices are not coming down fast and we're trying to pay for everything out of pocket? It's not possible. So that shows you kind of the distance between the theory and the reality. And I'd be similarly fearful here. Unless we took a more deliberate approach to really discussing, medical school debt, medical school tuition, et cetera. There are those who argue, by the way, and some of you will be familiar with these arguments, that the reason healthcare costs so much, it's not just the high technology, the state of technology, and specialized services. It has more to do with the fact that, for the most part, people are not paying out of pocket. So they're not aware of how much things cost. And as long as they're not aware of how much things cost, those prices really have no meaning to many people. Now, they have meetings suddenly when your insurance company decides, nope, not paying for that, right? But until then, they're relatively meaningless. And so that is an argument that's out there. And, under certain circumstances, that may well be true. But I don't think we want to risk it and attempt the alternative. Any other questions, comments?
I was wondering, actually, do you have like a vision for of the existing healthcare systems around the world? Do you have like a model that you say that would be best adopted in the United States?
That's a great question. I have to word this carefully because, actually the systems I, tend to admire most as they exist currently are those that don't fit the classic definition really of single payer, but get pretty close. So I have in mind systems like those in Germany and the Netherlands, possibly Switzerland as well. And those systems have a bunch of payers. In Germany, they're not called insurance companies, they're called sickness funds. I love the German term for it, by the way. It's Krankenkassen. And yes, you have to say it that way. I'm German, so I can say that. Anyway, German descent. So there they have a bunch of payers. So it's not really a single payer system, but, and this is the crucial point, all of those, hundreds of, what we would think of as insurance companies look nothing like insurance companies in this country. So they are heavily regulated. They are based on occupations. So people in different occupations tend to have the same sickness fund. Different regions have their own sickness funds as well. They all offer pretty much the same sort of product. They're all required to offer the same sort of product. And there are mandates when it comes to how much they can charge individuals as well. So these are very heavily regulated, sort of quasi-private, quasi-public organizations. And they negotiate directly with the national body of physicians, for instance, over reimbursement and the like. And the same prices, roughly speaking, apply in most cases around the country. And so, I see a system of that like that as working very well. They have achieved near universal coverage. Prices are reasonable for individuals. Physicians, while they don't get reimbursed as much as they do in the United States, tend to do pretty well as well. So this is a system that to me looks to work well, and practically speaking looks like something we could do. It looks nothing like, it's not socialized medicine by any stretch of the imagination. And so those are the sort of systems that I tend to admire the most, and that I think, we could potentially borrow in the United States. Now, I still think it would be difficult because, the fact is that, it's all well and good to say that, well, we could make our existing insurers into, much more heavily regulated, almost utility like entities, right? Well, we would be up against the lobbying of all those insurance companies, and that's much easier said than done. So even something like that doesn't follow the classic single payer, sort of rule book would still be rather difficult. But I think it's something that we could do, and again, it's been shown to work fairly well. Germany is the grandparent of national healthcare systems generally. They came up with the first national healthcare system all the way back in the 1880s. And it has followed the same structure, really, same fundamental structure through all that time. So talk about a system that has stood the test of time. I think there's a lot to be said for that, and it's a reason why the German system has been copied, with variations in Japan, for instance, and many other countries around the world. So I think the United States could borrow a lot from there. It would still require a lot of changes, and it would still necessitate, quite a bit of opposition from the current players in our healthcare system. That's what, remains the most difficult challenge, is that, whereas many countries, when they developed their national healthcare systems, there was only a very small, for instance, health insurer, presence really. Healthcare systems generally were kind of in their infancy. Today, we have a healthcare universe that is populated by all manner of powerful players, many of which individually are highly effective, well-endowed lobbyists, and can do quite a bit to stymie change. That's what's really most difficult about fundamentally reconfiguring our system. And that's why when it came time for the Obama administration to consider reform, instead of fundamentally reconfiguring it, they effectively, came up with a system that rested atop our current system. So that's why we get the reforms that we do. Now, again, is it impossible to envision other sorts of reforms? Absolutely not. And this is not a reason, by the way, to not fight for a more equitable system. I just like to highlight, the fact that there are obstacles obviously in the way.
So as we near towards 4 o'clock, I do want to be respectful of everyone's time. We definitely want to hear everyone's questions, but if you do need to take off, by all means, thank you very much for joining us. I will also ask, does anyone else happen to have any last minute questions?
Yeah, I wanted to ask you if, here we are, we're in a system or, collection of different agreements or what have you, potentially wanting to have this single payer system or universal health care. Has it happened the other way around? Have there been countries or places where they had that and wanted to be like what we have?
That's an excellent question. And, right off the bat, I can't think of any cases like that. It's moved in the opposite direction, many times. So we've had, situations like Switzerland, for instance, which up until the 90s had a system that looked a lot like ours. And they developed a much more heavily regulated system that looked more like Germany's and the Netherlands. Italy was the same way, had a system that was pretty freewheeling like ours, moved toward a system that looks more like the NHS than anything else. So what I will say is that, in some of these, systems like the NHS, let's take the case of the NHS. There was a time during the 1980s under Margaret Thatcher, in which the Thatcher government decided that what the NHS needed was the discipline of the free market. So they introduced limited competition, what they called, managed competition within the context of the NHS. It actually went by the name of the purchaser provider split, whereby GPs could use money that they were given by the government to purchase services from competing hospitals and competing specialists. Even that, though, was very limited. And even someone, like Thatcher, who privatized entire industries, knew that she couldn't get away with, fully privatizing, certainly the NHS. It just wasn't going to happen. So there have been some steps, and there were, in the 1980s and 90s, particularly around the fall of the Soviet Union, in those systems that were more public, more nationalized, to try to introduce some, elements of privatization within those systems, but none of them, switched over toward anything that looked like the American plan. So. Yeah, so there hasn't been a case to my mind of someone moving from a single payer to an American style system, quote unquote system, not really a system.
Hi, Dr. Ehlke.
Hi.
I have a question. So, sorry, I have ambulance in the background, but is the reason why we have not gone towards like national health insurance, like you just mentioned, because we have a federal government and a state government, and the fact that we have a division between Republicans and Democrats? Is that the reason why we haven't moved towards that?
Yeah, great question. I think it's much more the latter than the former. So, it's because of really the polarization between the two parties, between Democrats and Republicans today. And, if I were to identify, a factor, it's interesting. It was not always that way. There used to be more progressive Republicans that were receptive to the ideas, of making, the healthcare system more equitable. And there were many conservative Democrats who didn't want to hear anything about it. But today it does break down much more along party lines. So there are, literally zero national Republicans, certainly, who would sign on to anything close to single payer. So it is bound up entirely within the political fortunes of the Democratic Party. And, not every Democrat is in favor of single payer as well. So it's partly a matter of convincing Democrats that this is in their political interests. But certainly right now it breaks very much down on party lines. So in a situation where the Republicans look, certainly it's possible that they could regain the majority in both houses of Congress, that pretty much shuts down that discussion, for another couple of years at least. So yeah, I would point much more to that. When it comes to federalism, the fact that you have so many states and a division between the state and the federal government, in some ways that can make it more likely that you'd see a move towards single payer, simply because if it works well at a certain state level, that it becomes possible, maybe not likely, but possible that might get picked up by the federal government. So certainly I wouldn't say that that's a bar in any way toward establishing, something approaching single payer. And we have Medicare already, and that applies, across the country. When it comes to changing the law, it's actually, as a legal maneuver, it'd actually be very easy just to strike out, a few lines or change a few lines of the law governing Medicare, for instance, and to, reduce the age of eligibility from 65 to 0, make it eligible, make everyone eligible. In one stroke of a pen, you could literally move towards single payer. Now, as I said, Medicare as it stands has major gaps, so you probably wouldn't want to do that. But theoretically, you certainly could. So federalism would not stand in the way of that. But partisan polarization absolutely is, I think, one of the most significant obstacles toward movement in that direction. All right. Any other questions or comments before we go?
Last one.
Sure, please.
I feel like the arguments against this change are really accessible in the context of, I could see why insurance companies wouldn't want this. I could see why hospitals wouldn't want this, or providers, etc. But the everyday citizen, what's their argument against it?
Several fold, I think. One, there are some who are fearful of higher taxes. This most single payer plans would come with a rise in taxes, particularly again, on those who are relatively better off financially, right? So, for those who do find themselves, in the, upper reaches of the middle class, perhaps, looking at increased taxation is not something that they relish. Moreover, many of those same people currently have employer-based coverage that, it may go too far to say that they like their insurance. No one likes their insurance, let's face it. But it's familiar to them. It's a known quantity. And especially for those who have very generous insurance policies through their employers, it's not something that they're readily willing to give up in favor of a government program, no matter how much you work to convince them that this will be just as good as the coverage you have. The fact is, it remains unknown to them, and so I think that accounts for a large part of the skepticism, among at least certain parts of the public. So that's why in the polling, when you ask about should we have a national health insurance program, single payer national health insurance program, it scores very high. Something like 70% of Americans say they support it. But then if you add the question, this could mean you losing your current employer-based coverage in favor of a government insurance plan, support tends to drop off dramatically. And so I think that in large part is why many people oppose it. Other people have, ideological reasons, as well. So, they have a certain loyalty to, favoring, the free market at return. So there's an ideological element there too. But others have practical concerns, certainly. And so partly, how do you get around that? Well, it's partly about educating, right? Making sure that people know that the government plan on offer will be, in most cases, just as good as the plan you have currently, and it will be a lot simpler. There will be a lot of elements that are better in many ways. But it's about getting that message out there. And right now, that's somewhat lacking, I think. Thank you.
All right.
All right. Anyone else? Yeah.
Vivek had to run to the hospital, but if anyone else has any questions, I think we're hitting the end of the time, but feel free to email us or email Dr. Ehlke. Thank you all for coming, and thank you very much, Dr. Ehlke, for giving your time and this excellent lecture to SNaHP.
Absolutely. Let me put in my email address in the chat before we close out.
Yes, absolutely.
So that anyone who has any questions, after the fact, I know I go to many presentations. I don't have a question at the moment, but then, a half hour later, I'll be walking down the street and be like, oh, I should have asked that. Why didn't I do that? So let me just type in my email address to everyone. There we go. Please feel free to send me your additional questions or comments. Happy to help. And thank you, everyone, both in New York and Rhode Island, or anywhere else you might be joining us from, for joining us today.
Thanks, Dr.
Thank you. Have a great weekend, everyone.
Thank you.
Thank you.
Thank you. Thanks.
Take care, everyone.
You too.